So I'd like to invite Dr. Honegger to come up and Dr. Ling to stay. I'm sure there are questions from the audience, and we have about 10 or 12 minutes for them.
Hi, thank you. Carla Kaufman from University of Calgary. Thank you both for really great presentations. So I have a question for Dr. Heiner. I have an interest in hepatitis B in pregnancy. I wonder, do you know if there's any data for hepatitis C with respect to viral load threshold or cutoff in terms of risk of vertical transmission? And then my second question is, it's interesting that you commented that they've been able to determine from the quasi-species that the infection probably occurred early in pregnancy or middle of pregnancy. What's the postulated mechanism of the virus crossing the placental barrier?
Good. Thank you for the question. The first one about viral cutoffs, there's definitely no safe cutoff that's been identified, but several studies have suggested that above 10 to the 6th was associated with higher risk, another 10 to the 7th. You'll find other studies that aren't able to find a cutoff, and they say it has more to do with association of the virus with PBMC's transfer. Regarding the second question, can you remind me what it was?
Well, maybe you sort of answered it already, but in terms of the mode of transmission from crossing the placental barrier from mother to child.
I don't think it's firmly worked out for sure. As far as in utero transmission, there's some evidence that some of the receptors necessary for entry are on trophoblasts. So there's question of whether there's trafficking through trophoblasts or whether there's trafficking through attachment to lymphocytes that traffic, or just microhemorrhaging of the placenta, and then at birth, microhemorrhaging and contact with vaginal fluid.
Thank you.
Yeah.
Hi, it's Steve Martin from Calgary. I have a question for Dr. Ling. Simon, Harvoni was approved in Canada in 2017 for adolescents, and the Mavorite medication for adolescents last year, and we anticipate for 3 to 18-year-olds, 3 to 12-year-olds in the coming year. And yet, not just in Ontario, as you mentioned, but probably most of the provincial special authorization programs specifically state only for adults. And while pediatricians can get the medication approved, it takes many rounds of application and reapplication in order to get that approved. If we're going to be serious about the blueprint and having accessibility to treatment for approved medications, what does it take for us as a nation to make it easier for access to children and adolescents?
Yeah, it's a great question. I think it is, in our experience, something of a black box to figure out how decisions are made around this. What would I suggest that we do? I think we probably need to come together and advocate for our patients and have our patients join us in achieving that important goal. I think the combined voice is where the power will.
Do you think some of our partner organizations that help support this conference could help with that?
No doubt.
Great. Thank you both for the excellent talk. You mentioned that one of the risk factors for advanced liver disease in childhood is the presence of steatosis. Is there any evidence from any of the treatment data that you were reporting of change in lipid profile, change in fatty liver disease, change in CAP scores with successful DAA treatment?
In the pediatric studies, I'm not aware of any data on that people have looked at that.
So, that could be another argument in favor of offering therapy to this population, is that it can not only eliminate Hep C, but change the course of obesity or fatty liver disease in these kids.
Dr. Curious, I'm Hong Chun from the University of Calgary. I'm just curious, around 40%, up to 40% will be eradicated simultaneously. Another thing is, if you leave it untreated, some patient will go to cirrhosis. In this case, in which situation you need to wait, and which situation you need to treat the patient?
So which patients should you wait for,
You know-
and which should you treat?
Up to 40% will be eradicated simultaneously. Yeah, will be cleared simultaneously.
Yeah.
And the other thing is, if you won't treat the patient, some of them will go to fibrosis, cirrhosis. So how can you kind of a dilemma? How can you decide whether you treat the patient or not?
So I think there are different reasons to treat patients, one of which would be to prevent cirrhosis, knowing that not all children will develop cirrhosis. And the second part of your question is how long would you wait to see if patients are going to clear the virus spontaneously? And I think taking the second part first, I don't think there's any pressure, or there's minimal pressure really usually to treat children at 3 or 4 years of age. And there is a small chance that those kids who have not yet cleared their vertical transmission will go on to clear between, say, 3 and 7 years of age. It's a diminishing return, but it still can happen. So treatment beginning from 6 or 7 years of age would seem reasonable to me. I think we're often in discussion with parents and caregivers around the timing of that sort of thing in terms of our testing previously, and we'll see how that translates into clinical practice when we start to be able to treat those young kids. We haven't got there yet. In terms of whether to leave children untreated once they're into an age group where there is an approved treatment available, or if we could identify those who are not going to develop advanced liver disease, to leave them untreated. I think for me, the argument there lies in the impact on their quality of life for the individuals and the potential for transmission by them to others as they grow older. So for those reasons, I think there is evidence for universal treatment for all kids once you've identified that they have hepatitis C. That would be my approach.
Thanks.
You have a question?
I may have a question for Dr. Honegger, but Dr. Link can certainly butt in. You alluded in passing to maternal co-infection with HIV. Could I hear your thoughts about the effect of this co-infection, for example, on postpartum viral rebound, clearance, or mother-child transmission?
Regarding maternal co-infection with Hep C and HIV, the most straightforward facts, I think, were that there definitely were higher rates of Hep C transmission in women who had HIV Hep C co-infection if the HIV wasn't well controlled. And then with the initiation of standard art therapy, there's that excessive risk of vertical transmission of Hep C seems to be declining, maybe close to what it is for mono-infected women. We have not enrolled a lot of women who are co-infected in our studies. The epidemics are still largely separated in our local community. So unlike what you study, I've only studied 2 women with co-infection. One of them did clear Hep C spontaneously postpartum, though, but her HIV, we just started therapy with that pregnancy. Yeah.
Bishoy Aziz, University of Alberta. I have a question. I know it might be a little bit early to ask it, but do you think that the benefits outweigh the risks for treating pregnant mother rather than waiting till delivery and treating both the mother and the infant if the infant proved to be sick, and also about the cost effectiveness of treating two patients, the mother and the infant, compared to treating possible teratogenicities of the drugs?
That's a good question about whether it makes sense to just wait, treat the mother postpartum, and if the child is infected, then treat the child. And I haven't looked at the cost effectiveness. Obviously, there'd be more screening costs, presumably, if you wait. But only one of the 20 children might be infected, so you wouldn't be adding a lot to the treatment costs if you just treat infected children. And I think that's a very important point and needs to be considered. Some obstetric friends are upset when I suggest, why don't we just really focus on improving follow-up for the mother, testing of the infant, and treat those babies who are infected and treat the mother postpartum. And so it's definitely a dilemma at this point. What's the right thing? For sure, I think we shouldn't be cowboys and just start treating during pregnancy without further study. And I meant to follow up on the first question about the risk of transmission. Which women would you treat in pregnancy? And if there are women with high titer viremia or other risk factors that are identified for transmission, maybe those would be the ones to start your studies in. So.
Jordan, a very quick question.
Very, very quick question. Thanks for the presentations. In the Chappelle study that they presented at Croy, did they talk about how they ruled out cirrhosis in the mothers? It's not so simple because FibroScan is not approved in women, and none of the serology tests are accurate in pregnancy.
All I know is they specifically stated was that they had those limitations and they couldn't do elastography in pregnancy. And so I think it was just based on a medical history and impression prior to pregnancy of whether there were signs of testing or whatever testing was done before pregnancy.
Thanks.
If I can just make one quick follow-up comment, because I just had the opportunity to review the literature about this, and that FibroScan has been done in pregnancy. There's been a few studies that's been validated throughout different trimesters. It does go up, the liver stiffness does increase, but then it goes back to normal, which may be related to your presentation about the immune reconstitution and how that can change during pregnancy.
So are they, there are changes that occur with pregnancy. Are they still able to distinguish cirrhosis on top of that?
No,
or
not
in the
cirrhosis,
background?
but like the stiffness increases, but it then goes back down to baseline. So based on this sort of literature, they say that it can be used in pregnancy or validated to rule out advanced fibrosis.
Okay.
Yeah.
Carlo, do we know that fibroscans are safe in pregnancy? Because I didn't know that.
They're not approved. That's exactly the point. They're not approved, but we do them all the time.
Oh, okay.
Yeah.
Good to know. Thank you.
And with that, I think we will have to move on. I'm thrilled at the level of interest in maternal and child health relating to hepatitis C infection. Thank you so much to our speakers.